class. I'll be recording this lecture today. I'm sure you're aware that we usually record our lectures and we upload on YouTube. And yesterday was a public holiday. We usually do it on Tuesdays, but because yesterday was a public holiday, there wasn't a lecture yesterday. So today, I'll need to record our session. So basically today we're going to look at the topic of one of the topics under your anti-inflammatories and analgesics that we didn't cover last week, which is migraine. We'll look at that, and then we go into today we have to do opioid analgesics and anesthetics and general anesthetics and pre-medication. General anesthetics and pre-medication. So, okay. So those are the things we need to cover this morning as we're here now. Okay, but just to take us back quickly to what we looked at last week, we talked about anti-inflammatory agents and analgesics. We tried to differentiate between analgesics and anti-inflammatory drugs, and we saw that analgesics will actually work for pain, while your anti-inflammatory drugs will also work for pain, which is analgesia, and help reduce inflammation. And like analgesics, they also have antipyretic activity for fever. Okay. Then we saw the different pharmacological effects of the use of the different groups of drugs. Okay. Of the different of the use of these different groups of drugs, we had corticosteroids under your anti-inflammatory agents. We had for analgesics, we had paracetamol as the drug of choice. We saw aspirin as your atypical non-steroidal anti-inflammatory agents. Then we saw your other very traditional anti-inflammatory agents that would inhibit both COX-1 and COX-2. And then we looked at the selective ones, which would only inhibit COX-2. And so we have our GIT cytoprotection still in place because they would not inhibit COX-1, and we can still enjoy the benefits of COX-1. Then we saw the side effects that come along with using this drug. We saw those some CNS side effects, the GIT side effects, and all of those other things we saw. And we saw the reason why you wouldn't want to use NSAIDs for an asthma patient, someone who is hypersensitive or allergic to, has allergies. You wouldn't want to use that for them. And the caution we would need to take if we have to use NSAIDs for persons with ulcer, or to reduce the incidence of ulcer. We saw the mediators that are involved in the inflammatory response, and that's your prostaglandin that are responsible for mediation of pain, and your cytoprotection and other things. And we saw when we inhibit COX-1 and COX-2, what happens and how this happens. And we saw thromboxanes as well. Thromboxanes work for platelet aggregation, all right? So if we inhibit thromboxanes, then we help to reduce platelet aggregation, which is one of the reasons, or one of the main pharmacological advantages that your aspirin has, because it irreversibly binds to or blocks your cyclooxygenase enzymes, while the other ones reversibly block your cyclooxygenase enzyme. The reason why I'm doing this is because then we saw gout and rheumatoid arthritis. We saw their inflammatory conditions that require anti-inflammatory drugs. All right, and so we looked at the different kinds of anti-inflammatory drugs that can be used for these conditions, and the specific ones that would help to stop the progression of the disease, particularly your DMARDs for rheumatoid arthritis. And we saw colchicine is a drug of choice for acute attacks of gout. Allopurinol and probenecid work in different ways for your maintenance therapy or for chronic cases of gout. Okay, so when we go to, let's start with the one we didn't finish last week, which would be the migraine. So migraine is, it's a type of headache, all right? If I don't know how aware you are, but there are different types of headache. You could have your tension headache, your migraine headaches as well. So different kinds of headaches. Migraine is one of them. Migraine has a genetic and an environmental cause, all right? So sometimes people or individuals are predisposed to developing migrainous attacks based on their genetic makeup, and sometimes as a result of the environment they find themselves in. So migraine is characterized by first an aura. It starts with the patient experiencing, not all patients, some patients will experience an aura. That's a feeling of visual disturbance for the patient. A feeling of visual disturbance. It has an aura. It's also characterized by a throbbing headache that starts unilaterally. That means it starts on one side of the head, but usually progresses to both sides of the head. So you have nausea also accompanying migrainous attacks. So this condition is said, you would think it's just a headache, but it's quite debilitating, because when individuals suffer from a migrainous attack, most often they are not able to carry out their daily activities. So school hours, work hours, life hours are lost to this condition as well. So it's something that we really need to be concerned about and be able to help our patients with. So migrainias are persons who suffer from a migraine attack. So you would have, sometimes the frequency can be more than one episode per month in some patients. I remember when I was in high school, I was in a boarding school. I had a roommate, I think I was in the early phases then, probably you call it grade 7, grade 8 or 9 then. We had a roommate, she was in probably grade 10 or 11, but she used to have this frequent migraine attacks, and each time she had it, we would not be able to put on the lights of the room because of the photophobia that accompanies the condition, and she would be on her bed with a blanket, with a pillow over her head. So for those periods, she wouldn't be able to go to class, and that's how debilitating it is. So I had a close experience with someone who had this attack as well. What's the pathogenesis? How does this condition occur? So there is a chemical mediator that is implicated in migraine, and that is your serotonin 5-HT. Are we familiar with our mediators? Serotonin 5-HT is implicated in the incidence of migraines or migrainous attacks, and with other mediators, but it seems to be the main mediator that has been found to really influence the incidence of migrainous attacks. So you have so it's divided into two phases. I already talked about the aura in classic migraine, but not all patients get this aura, which is accompanied by your visual disturbances and depression and pain and all of that. But so we have it in two phases. The phase 1 has to do with vasoconstriction of the intracranial blood vessels in the brain, okay? And it's said to be due to the release of that chemical mediator that I mentioned, serotonin. So when serotonin is reduced, it causes vasoconstriction in the individuals that are prone to these attacks. Then, because of the release of serotonin and your vasoconstriction, you have all those other things. The prodrome, which is your preceding signs, also accompany. So your prodrome, so the aura is what the patient actually first feels. Sometimes the prodrome and the aura are used interchangeably. Actually, to differentiate between the two, it's a bit difficult. So your prodrome, I don't know if you've heard of prodrome during any of your other lectures, are symptoms that you see before the actual disease onset. Do you get it? Like for your infectious diseases, like measles, or let's say chickenpox for children now, sometimes they'll just be feverish, but they don't have any rash, they don't have anything. You just see fever, they're irritable, they're crying. When you check and try and assess them physically, you cannot see any other sign apart from that this child is irritable. So that's your problem. That's what it's supposed to signify that there's an organism causing discomfort in the body, and it's giving the child those signs of discomfort as a result of what's going on in the body. So it might take a bit before you would see the actual clinical manifestation of the disease. Like with those infectious diseases, before the rash, the onset of the rash, the child would have those prodromes, and they will present with those symptoms. Also with migraine, the patient would have those visual disturbances and mood changes and depression and all of anorexia, and all of those things can accompany, particularly the visual disturbances, having a vision like a black spot behind the eye. You're looking and your vision is just distorted. There's a black spot behind the eye, and you're not seeing, like you're looking through a lens. You're not seeing properly. These are kind of prodrome symptoms that the patient will present with. So phase 1 has to do with, just take note, phase 1 is vasoconstriction that occurs in the intracranial blood vessels due to the release of serotonin. Then phase 2 has to do with, after the vasoconstriction, we have the process of vasodilation. And it's the vasodilation that results in the throbbing headache that the patient now gets after the prodrome or the aura of the visual disturbances and all the mood changes that I explained earlier. So it could start, this throbbing headache could start in the eye, or it could be all over. It could be diffuse or unilateral. It could be all over or on one side of the eye. And this is said to be due to the rapid the vasodilation now causes the rapid metabolism of your serotonin mediator. So when the serotonin is metabolized, it results in that vasodilation. And so you have the throbbing headache and all the other things, photophobia, cold cyanotic extremities. So the hands and the feet are quite cold, and what cyanotic means, bluish, almost like bloodless in nature at that point in time. And then you would be able to see the extracranial arteries, because I don't know if you've ever had that kind of, even if it's a tension there, where the pulsation of the artery is so prominent that if you put your hand there, you can actually feel and you can actually see the vasodilation that is going on there. All right, so the increased amplitude of pulsation is also thought to be due to the stimulation of beta adrenoceptors by adrenaline that is released in the body. Okay, so that's phase 1 is a vasoconstrictive activity based on the release of serotonin. Your phase 2 activity is based on the metabolism of serotonin, which results in vasodilation. And it's the vasodilation, vasodilation means the vessels are open and more blood is being pumped. That is responsible for the throbbing headache that the patient presents with. So what are the factors that usually precipitate a migraine? The factors that I have a few here: anxiety, tension, starvation, exhaustion, flashing lights. Sometimes food, particularly food that contain tyramine, would induce the onset of a migrainous attack. Or chocolate could also be responsible for those attacks. All right. Does anybody else have any other factors or know of any other factors that could cause a migrainous attack? Has anybody ever, had anyone close have a migraine attack? You know that you've never experienced it, you've never seen anyone have it. Okay. So something is said to be more prominent and more common in women than in men, and it sometimes is attached to your menstrual cycle to influence the onset of all the migraines attack for women. Women, definitely. And then stress, which we have seen here, is also one of the reasons why. And it's sometimes it's more common in puberty than in puberty to the tatters, and those are the ages where it is most common. So sometimes you might even be having a migrainous attack, but because you cannot differentiate between a migrainous attack and other kinds of headaches, you think it's just an ordinary kind of headache that you're having. But as we get older, we somehow, it fizzles out and the patient doesn't have this those attacks anymore. So treatment depends on the correct diagnosis. Like I said now, I'm sure there's many different people that are having this kind of headaches where they just think it is a regular kind of headache, particularly for a woman or a teenager who has premenstrual syndromes or symptoms. And so when these come on, you think it's just part of my menses and there's nothing big about it, but if it is debilitated, please advise the patient to seek proper medical attention, because there might be more to that. So correct diagnosis is very, very important. And how would we be able to correctly diagnose this situation or this condition if we know the pathogenesis, which is what we have described earlier. You know that in the previous slide, you know the pathogenesis, you know how it presents, the symptoms that go along with this condition. And then the elimination of the causative factors where it is possible. Like if it is the food that someone is eating that usually brings it on, then you can advise them to stop eating those kind of food. So you need to take a history. I'm sure you've done history taking. Take a history and find out what is wrong with the patient. When does this happen? What are the circumstances that surround the onset of a migraine in such patients, so you can help them eliminate any causative factors that might be implicated. Then the determination of appropriate medication. So we'll see now when we go to the treatment that there are various medications for the different types of medication for migraine. So it's important to be, and they work differently for different people. We know about idiosyncrasies and all of those things, and the different genetic makeups, and how these factors influence our response to different drugs. So we need to be able to help our patients to use the appropriate drug that would help their health outcome, so they can live a much better health outcome. So before we go to the treatment and control, I already talked about the symptoms of migraine. And for the symptoms of migraine, we saw that there is pain with a throbbing headache. There will be pain. There's nausea and vomiting as part of the symptoms. And then irritability and anxiety is also part of the symptoms of migraine. So if we look at these drugs, based on the lectures we've had so far, which classes of drugs will be suitable to use for a migraine patient? When you talk about pain, analgesics would work there for pain, good. Nausea and vomiting, antiemetics. So no, we haven't done that yet. Have we done antiemetics? I know, have you done antiemetics already? Am I not teaching antiemetics? So I don't need to teach you, right? When we get there, I'll just skip. So nausea and vomiting, you will need to use your antiemetics. Irritability and anxiety, chapter 6. Anxiolytics, and all of that would work for irritability and anxiety. So you already have pardon? Yes. Is that a question?
Yes, I have a question. What is the difference between normal headache and migraine?
When did you come in?
Huh?
When did you come into the class? Were you late?
Yeah, I was late about 5 minutes.
So were you here at the beginning? So I mentioned the symptoms. That's why we're giving this symptoms that you see here. That's the way you'll be able to differentiate between a migraine and any other kind of headache. The aura, the prodrome that precedes the headache itself. So it is a multifaceted condition. So it comes in phases. You have the phase of the aura or the program where the patient has the visual disturbances and the mood changes and the depressions, like 48 to 72 hours before the onset of the headache. Remember, migraine is a type of headache. So before the patient gets the headache, they get this feeling, this aura, this depressive moment, this discomfort without the headache being present already. So that's another one way of being able to tell if it's a migraine or not. And then the different phases, so that will be your phase 1. Then your phase 2 will be where you will find that phase 1 and phase 2 will be where you will find your phase 1 is where you will find your vasoconstriction, and phase 2 is your vasodilation. And the different symptoms that they're so this it's you can't say that phase 1 happens and it stops. So they're interlinked in some kind of way. You can actually, it's not cut and dried and in stone. So you can't actually say, but if the patient presents with this, you'll be able to tell the difference that this person is presenting with a migraine. So you have anorexia, nausea, the patient cannot eat, okay? So they lose weight within that period, and that also causes problems for them. Irritability, nausea, and vomiting, okay? So headaches that come with such kind of symptoms, we need to check to make sure it's not. So we already have an idea of what the treatment that we will need to use in a migraine attack or for a migraine patient presenting with migraine. So we already talked about analgesics. So analgesics that I use, usually you would have your opioid analgesics, which we're going to look at later. Not later, immediately after this we look at opioids. Your opioid analgesics, aspirin, paracetamol, codeine, or your propylxyphene can be used for the patient. But you want to use the opioid analgesics in combination with antipyretic if aspirin, paracetamol, and the others are not relieving the patient of the pain. So you always want to start with the safer medications. Remember, we do that now with opioids. What's the main issue with them? What's the main issue with the use of opioid analgesics or opioids in general? Addiction, tolerance, dependence, and all of those things. So we'll like to use other alternatives. If the patient is doing very well on your other analgesics, then fine. You don't need to go on your opioid analgesics. And then we saw antiemetic, your cyclizine, to prevent nausea and vomiting. Okay, use 30 minutes before other drugs if the patient is prone to vomiting. So you want to ensure that whatever other medication you give them stays inside. That's why you use it 30 minutes before the other kinds of drugs that you're going to give the patient. Then your sedatives, the anxiety, the irritability, you want them to relax, and diazepam is a drug of choice there. So in addition to using all of these drugs for migraine attacks, for the analgesics to work effectively or quickly, for the onset of action to be quick, you would also combine your domperidone, all right, or metoclopramide. These ones help to increase GI motility, so the patient wall can be empty, and the analgesics will be able to be absorbed quickly into the system and be effective as soon as possible. So aside this drug, so what we've seen now from the list of drugs we looked at earlier, what are they treated? Your analgesics, antiemetics, sedatives, and even your domperidone that help with improved absorption of analgesics. What's the purpose of those classes of drugs? From what you've seen, or we've said so far. For pain. So what are they treated? Pain. What's the general name for what they're treated? The discomfort, the symptoms of the condition. Remember, what did we say is responsible for the migraine? Serotonin. Okay, so we have the vasodilation and vasoconstriction caused by serotonin. So if we actually want to treat a migraine, what should we be inhibiting, like we saw with our NSAIDs? Serotonin is the bad guy that we need to get here. Okay, so So all the other things we've looked at now, they will help the patient to feel better. But your vasodilation and your vasoconstriction, are they still going on? Because serotonin is not inhibited. Okay. So you have your triptans, which are the treatment of choice for migraines. Why? Tell me, why are triptans the treatment of the drug of choice? For specific serotonin receptors, so they can cause constriction or dilate, so they can inhibit the activity of serotonin that is responsible for the symptoms that we're seeing here. Do you understand where I'm going to? So they can actually act on serotonin. They can inhibit serotonin activity. So they inhibit the release of sensory neuropeptides, and they are well tolerated and very effective as well. So what do? They cause constriction of dilated vessels. What happens? What do the dilated vessels cause? The throbbing headaches. Okay? The throbbing headaches that the patient presents. Okay, so that's your triptans, drug of choice. Take very good note of that. The triptans are the drug of choice for migraine because they have a high affinity for specific serotonin receptors and can cause a vasoconstriction of dilated vessels. Okay, another group of drugs. So this triptans we saw are well tolerated and they are very effective. Another drug that is used for migraine is called your ergot alkaloids.
I have a question is when you said aspirin is contraindication to the person who has stomach inflammation. So
Stomach inflammation.
yes, and if that patient has stomach inflammation and he often develop a migraine, is any drug of choice you can give to that patient?
Those are the ones we've been looking at. We've seen a number of drugs that we can use now. So when we saw aspirin, we saw paracetamol as well. We saw opioids, which do not have any effect on the GIT. So the patient is safe to use any of those. And triptan, we've seen now, can act on serotonin. So there are other drug choices that can be made for such a patient. Are you okay? So we're not stuck on aspirin. It's not limited to aspirin for treatment. Okay. So ergot alkaloids, particularly your ergotamine tartrate, is used for migraine treatment. And what does it do? It vasoconstricts the extracranial blood vessels. All right? It causes the vasoconstriction of extracranial blood vessels. But this drug, ergot alkaloid, has serious adverse effects when used. Remember, so if we're going to compare ergot alkaloid to your triptans, what would we say? The number one thing we want to take note of is that triptans are safe and effective. They are well tolerated and effective. But we can see here that your ergot has serious adverse effects. Okay? And should only be used for short periods of time. And they're not suitable for prophylaxis. Examples of so they also can come in combination with other drugs. They can be added to caffeine, can be added to them, as well as cyclizine. Cyclizine is for what? Sedation. Okay, it helps. No, not sedation. Cyclizine is your antiemetic, not sedation. All right, and your caffeine. Okay. All right. So the adverse effects of ergot are it inhibit or sort of prevent its use in this group of patients. And one very, very important adverse effect of ergot is the retroperitoneal fibrosis and gangrene of the extremities. But if it happens, so I said earlier that different patients respond to different drugs. So sometimes someone will not respond to triptans, and you need to go to ergot, so you can use it for a very, very short period and well monitored. So it causes nausea and vomiting, but we know what we can give if it causes nausea and vomiting. We remember this preparation that has caffeine and cyclazine, so that is covered there. The most serious side effects that you can have with the ergot is your angina, tachycardia, and all of those things. And then it's contraindicated in particular patients that have peripheral coronary, cerebrovascular, renal, hepatic diseases. All of those diseases, you do not use ergot for patients that present with them. For pregnant women, we do not give them ergot, or persons with uncontrolled, this is uncontrolled, not unconstrained, uncontrolled hypertension, then you do not use ergot for such persons. So we said sometimes patients have frequent attacks of migraine. For such patients, you want to give them a prophylactic treatment to ensure, to help reduce the frequency of the attacks. And your propranolol, your beta blocker, can be used in that case. Pizotifin can also be used in that case, and flunarizine is another drug that can be used for the prophylactic treatment of patients that present with frequent attacks of migraine. All right, I think that will be all for migraine. Okay, I'll just quickly move over. I think I've changed the slides on Icamber as well. I don't know why this is the one I have here. To our CNS disorders. The reason why on your on the class schedule you find that anesthetics and premedication comes first, but I'm going to start with the opioid analgesics first. No, you are not the one I want. Wait, okay, yeah, there it is. Opioid analgesics first, because they are closely related to our anti-inflammatory and analgesics, because they also deal with pain and more active pain prevention as compared to our anesthetic agents. So we're looking at opioid analgesics. So this is they're on the CNS disorders. So I've gone back to chapter 6 to complete the topics you didn't do in psychiatry. All right. So this you didn't do in psychiatry. I'm doing it under in my section because it has a relationship to our analgesics and anti-inflammatory agents. So don't get confused about that. That's the reason why it is here. All right. So our learning outcome is to understand the mechanism of action of opioid analgesics. We need to know how it works. All right. Then every other thing that is there is our learning outcome. Look at that when you're going through your notes. So opioids, opioid analgesics are actually gotten from a natural plant called opium. I'm sure, have we heard about opium before? You've never heard about opium? Oh, seriously? That's interesting. So opium, or because you know it by other names, have you heard about muffin and codeine? Those are the products of opium. So they're all gotten from opium. But the reason, we looked at mechanism of pain and nociception when we did our analgesics and anti-inflammatory agents, and we saw that when there is an incursion into the integrity of the body, particularly the first barrier, which is the skin, either because of an infection or trauma or a cut or something on the skin, the body immediately notifies the immune system, and an action is taken to ensure that they stop whatever is invading the body, and the process of repair is also initiated. We saw that. And so as soon as there's a break in the integrity of the body, chemical signals are sent. It's these chemical signals that invite your immune system. And certain mediators and neurotransmitters are released, chemical substances are released from the body that ensure that that inflammatory process is carried out. And so they pass the impulses of the pain that is being experienced, that because of a swollen tendon or an inflamed tendon in the anyway the part of the body. So the message is sent across through your afferent nervous system to the brain, and the brain interprets it, and then the response is sent back through the efferent nervous system. So the the pain pathway is there as well. But it was found that when pain occurs in the body, there are endogenous opioid peptides in the body that respond to the pain perception that has been generated. And it was also found through research that this endogenous opioid peptide, so we said now opioids as morphine and codeine, and this all help to relieve pain. But it's found that in the body there are endogenous, as in the ones that are endogenous means that they are produced by the body. They're called endogenous opioid peptides. So the body has its own mechanism for modulating or managing pain. Okay? So there are opioid peptides that are naturally released in the body to modulate the transmission of pain in the brain and in the CNS generally. So they are referred to as your enkephalines, dinophanes, and your beta endorphins. Those are your endogenous opioid peptides. So they are naturally present in the body. Once there is the pain is elicited for whatever reason, these opioid peptides are released from the nerve endings of in the brain and the spinal cord to help to relieve the pain. So sometimes you have, I don't know if you've ever experienced that you get it's very, like you cut yourself. And some particular kind of pain, you get it and then you rub on it and then it feels better. So you forget that you had pain there. So you have something in the body that is helping to modulate, to intercept the pain, the nociceptive pathway. But in a situation where the endogenous peptides are not able to override the pain perception, then you need to administer extraneous or extraneous preparations that would help to relieve the pain. Okay? So for this to happen, as we should all know already, we need receptors in the body that this chemical substances, these endogenous peptides will attach to, for them to be able to inhibit or modulate the pain transmission that we receive on the stimulus being generated. And those receptors are called your opioid receptors. We are well aware of the specificity of receptors. So we have opioid receptors in the body that our endogenous opioid peptides would attach to on the generation of a stimulus of pain. So they attach to that and then they're able to modulate pain through that process. So when that was discovered, then that was when it was also realized that we can actually use our extraneously prepared opioids to help relieve pain. So if we take an opioid preparation, it will bind to the opioid receptors also that are already in the body, and they're present in many regions of the nervous system, like your primary afferent neurons and all those other places. So you have the receptors present. Once you use an opioid preparation, they bind to the receptors to cause your pain modulation or to relieve pain for the patient. So the mechanism of action is based on the ability of your opioid preparations to bind to your opioid receptors that are already present in the CNS and the nervous system of the body. There is more to it. It's not as simple as that, but your text doesn't require you to know the hyperpolarization, that the reduction of the CAMP processes that goes on. I would have loved to put that, but let's just leave it as you adjust the opioids. When you take opioid preparations, opioid analgesics, they bind to the opioid receptors in the body. And why is this effective? Because there are also endogenous opioid peptides that bind to these receptors and they help in the modulation of pain. So that is what about the idea that we can introduce external preparations and they will work the same way as what the endogenous opioid peptides do. Okay, so there are three different types of opioid peptides. We have the mu receptors, opioid peptide receptors, the mu receptors, the kappa receptors, and the sigma receptors. And they are the mu receptors are responsible for most analgesic effects. So when a drug binds to them, they can work for any kind of give analgesia to any kind of pain that the patient is experiencing. But if it's analgesia at the spinal level, the drug needs to be able to bind to your kappa receptors, all right? And then if it's peripheral analgesia that is required, the drug will be prepared to be able to bind to your sigma receptors. So during drug production or drug development, you prepare the receptors. So you know about affinity and efficacy of receptors and drugs. So you prepare your drug to have affinity and specificity for the specific receptors based on the pharmacological or therapeutic effects you want them to have. Okay? Based on the pharmacological or therapeutic effects you want them to have. All right, I already mentioned about opium. So the opium plant itself, this substances are obtained from the juice of the opium poppy plant, which is also known as our Papaver somniferum. That's the name of the opium plant. You can see there's a picture there. So I'm not doing slideshow. Let's do slideshow. Okay. So our opioid analgesics are obtained from the opium plant, Papaver somniferum. Okay. So there are over 20 different kinds of alkaloids that can be obtained from this plant. But the one that was first found to have analgesic property is your morphine. All right. So morphine was the first alkaloid of opium to be isolated in 1806, and it was discovered to be able to relieve pain. So morphine stands as our drug of choice for the relief of pain. Our drug of choice for the relief of pain. So we have, because it's obtained from this opium plant, we have different types of opioid analgesics. Those that can be obtained from the plant. Morphine is one that I mentioned now. So another one is codeine. Codeine can also be obtained from the opioid plant. So they are called your opium alkaloids or natural opioids. Okay? So you have your natural opioids, morphine, and codeine. Then you would have your semi-synthetic opioids. Oxycodone is one of those. Oxycodone rather is your semi-synthetic opioid. Then you have the fully synthetic one, your methadone and fentanyl are your fully synthetic ones. You should do your research.
Isn't fentanyl also flocka?
What's a flocker?
Flocka.
I don't understand that. What do you mean by that?
So yeah, I've heard that fentanyl is another word for flocka. Flocka is it's almost like meth.
Like what?
Like meth.
Are you talking about drugs that are used, as in drugs that are used for use in the streets? Okay. But let's see, Father. We'll see if you can confirm what you just said now. Let's see. So apart from the classification based on their source or preparation, which will give us the types of opioid analgesics that you have as the natural, synthetic, and semi-synthetic ones, we also would have opioid analgesics grouped based on the action or the activity they elicit when they bind to the receptor. Okay? The activity they elicit when they bind to the receptor. So we know that when a drug binds to the receptor, it's either an agonist or an antagonist, isn't it? An agonist, it produces an activity, pharmacological activity. An antagonist inhibits pharmacological activity, or particularly there is an endogenous substance that has produced this particular activity, and then you have an agonist extemporaneous preparation that is added or that is that attaches to the same receptor and produces a similar kind of activity, then it's called an agonist. If it stops that activity, then it's called an antagonist. So antagonism and agonism comes from there. So we have so opioid analgesic agonists and antagonists, as well as a group that are called dualists. They can be agonists and antagonists depending on the situation they find themselves, or the situation they use, the circumstance they are used for. So your agonist would, so we said morphine is the drug, is the standard for opioid analgesia or analgesics. So every drug, like I said now, if you have a natural or an endogenous substance that has produced a pharmacological activity, then we try and mimic that endogenous substance, do our own preparation, our formulation, and try and see if they can do the same thing that endogenous substance is doing, like our opioid, like our endogenous opioid peptides. And so they become agonists if they can produce the same effect as the standard drug. All right, and morphine has been confirmed to be able to produce analgesia when it binds to our opioid receptors. So morphine is our standard drug of choice for any. So if there's going to be a new opioid analgesic being manufactured anywhere, they need to test it against the action of morphine. Okay, so whatever relative to morphine, whatever activity it produces will determine its classification. So an opioid agonist will produce morphine-like effects. Do you understand it? If that is our drug of choice for analgesia, and for us to produce analgesia, it has to be an agonist, something that will do the same thing as morphine or our endogenous opioid peptides. So any opioid analgesic agonist would produce morphine-like effect for analgesia, to relieve pain in patients. And your agonists, as you can see from the slide, are subdivided into different classes. So not all remember we have three different types: synthetic, natural, and semi-synthetic. So they don't all produce the same level of analgesia like you've seen with your non-steroidal anti-inflammatory agents. They don't all work the same way. They work differently. They work for different presentations of pain. All right. So also with your agonist drugs, you see with codeine, though it's a natural opioid analgesic like morphine, it has a lower potency compared to morphine. All right. So all of this low potency intermediate, it's relative to which drug? To morphine. So when you say it has low potency, it's relative to morphine. When it has intermediate potency, relative to morphine. High potency, morphine is there. That's the chief of them all. So every other person tries to be like morphine. All right, but they can't because they have their inner. So the drugs that have high potency, you have morphine, fentanyl, methadone, and oxycodone. As the fentanyl is coming up again as a high potency, so your statement is being proved because it has a high potency. It could be one of the reasons why it's also used. Yes. So we have. So you have your agonist. So this one's the first 1, 2, 3 list of drugs that we saw will be your full agonists. So they can produce full analgesia when they are used, but at different potencies. So you have those that are called your partial agonists, your pentazocine, and your atypical opioid. It is atypical. It is different. You remember aspirin was an atypical non-steroidal anti-inflammatory agent. So tramadol is an atypical opioid. I'm giving you an assignment. Find out what that means. Atypical opioid. Okay? Make sure you do your research. You can meet it anywhere. What does it mean when tramadol is referred to as an atypical opioid? And I'm sure you've heard about all the noise and all the issues and events around tramadol. Are we aware of them? Tramadol has been in the news in recent times. All right, so let's see what it means and how tramadol is. Why tramadol is such a popular atypical opioid preparation. Okay. So pharmacological effects of opioid analgesics, you have we're already familiar with the fact that it causes or it induces analgesia when used for pain. But how does it do this? So what it does is to enhance pain threshold when it stimulates the opioid receptors. Can anyone explain that? Enhance pain threshold. We saw when we looked at pain, we saw it as threshold, it has intensity. And pain threshold is usually said to be from 1 to 10. Okay? Like if we expose everybody to the same kind of pain, the way you perceive the level of pain that you have depends on your pain threshold. Okay? Like if we say, I was giving an example that if someone hits their wrist against the steps, some person will just do that and move and carry on. Some person will do the same and break down here and cry. Okay? They will break down here and cry because they hit their hand. Because why is that? Because that person felt pain more than the previous person. Alright. So when you say that your muffin enhances pain threshold, don't use the word threshold. Can you use another word instead of threshold? You don't define a word using it. Your ability to withstand pain. So it increases your ability to withstand the pain. Thank you. Alright? So it enhances pain threshold when it binds to the opioid receptors in the CNS. So it actually doesn't do any other work with all the other sensory modalities in the body. The patient does not lose consciousness. It's not doing anything else apart from just making sure that you are able to cope more with the pain that you are experiencing. All right, able to cope with the pain that you're experiencing. So it causes so it may also, the patient does not lose consciousness. The pain, unlike with with NSAIDs where you have inhibition of the COX-1 and COX-2, prostaglandin is being inhibited here. Here it just does enhancing of pain threshold, and so it's also may cause sedation because of its one of the I don't know whether it's a good thing or a bad thing, is its ability to cause euphoria. That's a feeling of excitement in the brain. Okay? It causes euphoria, so the patient forgets about all the anxiety and fear and the panic they have around their circumstance. It's good for the person who has pain. If someone who's been in an accident, who's got cancer and all of those kind of things, they want to forget all of those things. But the human body also loves to be in that state continually. And so it's one of the reasons why you have dependence to opioid analgesics, because of its ability to cause euphoria. So it reduces your psychological sensations of anxiety, fear, and panic. So your muffin can relieve all types of pain, be it cancer, labor, whatever kind of pain the patient presents with. This organ pains from the organs of the body or any kind of pain, it would relieve it would give analgesia for such kind of pain. So that's for analgesia. So I want you to take note of this. It's how it goes about producing analgesia. It enhances your pain threshold, okay, due to stimulation of the receptors. It does not depress other sensory modalities. It doesn't cause unconsciousness with the patient, okay, and the ability to cause euphoria. Let's take good note of those points. Then another thing it does is pupil constriction, myosis or mydriasis in some cases. Respiratory depression is another thing it causes, right? So when patients use a morphine or your opiate analgesics, morphine, it causes depression or reduction of the reaction of the brain to carbon dioxide. That is always carbon dioxide concentration in the body. So the body is not sensitive to carbon dioxide concentration in the body. And this is what one of the ways in which it causes respiratory depression. And then it has an effect on the respiratory center in the brain as well. So, unfortunately, the normal dose, the regular dose of morphine will depress all phases of respiratory activity. So that's one of the downsides of using morphine. It can depress all phases of respiratory activity. It also causes nausea and vomiting. Okay, it causes nausea and vomiting. It has the ability to cause cough suppression in patients, and as well as hypertension. So when we look at this pharmacological effect of morphine, like with our NSAIDs, some are good and some are bad. All right, so we just take note of them. So when you look at the good sides, the good part of it usually will be your therapeutic uses of the medication. So that's another way to read your pharmacological effect of a drug. The good ones will be used for clinical uses, therapeutic uses. The bad ones become what? Side effects, adverse effects. Okay? So once you see it, once you're reading this, you say, okay, so this is a side effect, this is an adverse effect, or this is a clinical or a therapeutic use of this drug. Okay. So I already explained about it causes mood changes, which is your euphoria, which leads to your physical dependence. Physical dependence is a situation. Let's take a look at the definition of physical dependence. Physical dependence is a situation where a patient needs a drug, not necessarily for its therapeutic effect, but because the withdrawal or termination of the use of that therapy led to withdrawal symptoms, and the patient cannot cope with the withdrawal symptoms and wants the drug for that. Not necessarily because they're still having the pain, but because I'm feeling the way they're feeling, they want to use that drug. And this is possible. This physical dependence is more particular with the opioid analgesics that can cross the blood-brain barrier and have an effect on the CNS. Okay, they can cross the blood-brain barrier and have an effect on the central nervous system. Because for you to get to the central nervous system, now if you look at your text, unfortunately I don't have the page highlighted there. There's a diagram where it shows the drugs that cross the blood-brain barrier. I hope I'm talking about the right page now. Okay, maybe I'm talking about anesthetics now. But we can use that in your general anesthetics. You see, pardon? Is it one? Not this one. I think it will be in anesthetics and pre-medication. So because they can cross the blood-brain barrier, they can go and affect the central nervous system and cause those symptoms. So your codeine crosses the BBB, blood-brain barrier, very poorly, and so there is less dependence on codeine because it doesn't have so much effect on the central nervous system. Unlike urine, which it crosses so quickly and so easily that it has a high effect on the central nervous system, and so there is a high incidence of dependence on heroin as well because of its ability to cross the blood-brain barrier. Partial agonists, pentazocine, do not produce euphoria, so there is no dependence. So the ability to produce euphoria is related to your ability to cross the blood-brain barrier. So the more excited the patient can get on any of the opioids, the more they want it. Do you understand? The more excited, which is the feeling of euphoria, which is related to your ability to cross the blood-brain barrier and get to the CNS, the more the dependence, the more the wanting of that particular drug. So if you look at this list of drugs, heroin would be the one, that we want to avoid. If you want to place a patient on medication, we will try to avoid this because there is a high incidence of dependence on that. All right. Would rather want to go for codeine or your partial agonist, pentazocine. There is another partial agonist in your book. Tell me, what's the name? Is it? Okay, yeah, that's the one. All right. So those two do not produce euphoria, so they don't have any risk of dependence. So we saw dependence as the patient trying to not being able to condone or accommodate the withdrawal symptoms that they are facing as a result of the termination of therapy, because therapy needs to end. Once the pain is relieved, then we need to move on with life, isn't it? So some of the thing that happens with the use of opioid analgesics and the ability to elicit euphoria is called tolerance. Okay? So the patient becomes tolerant to the feeling of euphoria. Okay? To the feeling of excitement that they get from using the drug. And their body, because I said the body likes to feel excited, the patient would now need more of a drug. The body begins to accommodate the drug. Okay? The body begins to accommodate the drug such that you need more of a drug. The receptors need more of a drug. There is a desensitization that goes on. That the body, the receptors need more of a drug to produce the same level of euphoria or therapeutic effects. Like if 1 microgram or milligram was enough to relieve the pain that the patient had. Once the patient has used the drug for a long time, or for some longer than usual, for some it doesn't even have to be long. A first incident can breed tolerance and dependence depending on genetic makeup of the individual. Some people just use it for once and they become addicted. Do you understand? So tolerance is the longing of the patient to have more of a drug to elicit the same amount of euphoria or analgesia. So if 1 microgram was enough to relieve the pain, now the body has so accommodated the drug. There is desensitization that we need to 2 milligrams for the patient to feel better, to get the same relief or analgesia that they had with 1 milligram. So that threshold, we need to up the drug dosage to reach there. So it could just be because of for the euphoria they get, or for the analgesia they get from the drug. So we already saw withdrawal symptoms. Examples of withdrawal symptoms would be your lacrimation, rhinorrhea, and all of that. And this, in your textbook, at least, there's more to this. You can please read in your textbook the withdrawal symptoms, the stages, how it presents in a patient. So you'll be able to identify a patient who is experiencing this syndrome. Okay, so more effects will be the effects on the GIT. So we saw, I think when we were looking at it, we saw the effects on the GIT. So its effects on GIT will be its effects on the stomach, the small intestine, the colon, the gallbladder. What it does in the stomach is that it inhibits gastric motility. And when it inhibits gastric motility, that means it slows down. It slows down the release of gastric juices in the stomach. What happens if you have food in the stomach and a patient has been on morphine and it slows down gastric juices, the release of gastric juices? What's going to happen to the food in the stomach? Digestion is delayed. So digestion is delayed as well. It also reduces secretion of the secretions from the pancreas, the gallbladder, and intestine. So generally, it does what is called it causes what is called your opioid constipation because of its ability to inhibit gastric motility, the intestine. Also, apart from just reducing the secretion of juices, the intestines, those organs themselves, their peristaltic movement is also reduced. So if they were moving at this pace, it's slower. So digestion is generally delayed, and that will lead to constipation. Other effects also, it has effects on the urinary bladder. It suppresses bladder voiding and the uterus. It prolongs labor. Okay? Using your muffin as a standard here. In labor, you see here, it causes for the urinary bladder. It suppresses bladder voiding. So the patient who is on muffin will not get the urge to go and pee as often as they should get it. So they will have an accumulation of urine in them. Then the uterus prolongs labor, causes respiratory distress. We have seen that earlier. And this can lead to stillbirth. When there is respiratory distress of the child, it can lead to stillbirth. But this is for muffin because we have other opioid analgesics that are used in labor. Alright? It also causes your histamine release as well. So as we said, the pharmacological effects will give us the therapeutic uses as well as side effects or adverse effects of the drug. So when a woman is in labor, all right, and they're having acute pain. So that's why I said it's not generally that what we saw previously, it doesn't apply to all opioid analgesics. When a woman is in labor and they're having acute pain, you can actually use Petadine or pentazocine to relieve the pain they experience in labor. So morphine is the drug that you don't want to use when a woman is in labor because of its ability to cause respiratory dysphagia and to prolong labor. And cause respiratory depression. But if the pain, so we said morphine is a standard drug when we're talking about opioid analgesic, is the standard, is the most effective of drug. If a woman is in chronic or severe pain, that means persistent severe pain, and there is poor prognosis. What does that mean? It means it's possible that she might die. Alright? Like in cancer cases. And it's possible that a woman will die. So we can use morphine in such cases. But the slow release formula, because if the prognosis is poor already, the addiction or dependence or tolerance is not an issue anymore because of the poor prognosis. But if the patient has good prognosis, you don't give morphine, you give codeine or pentazocine. So depending on if a patient has chronic severe pain, like in cancer cases, morphine is used as a slow release formulation. But if the prognosis is good, you don't want the patient to get better because you've used an opioid analgesic, and then they start dealing with the problem of addiction afterwards. We already talked about cough suppression in the medulla. So because of so we said, when we look at the pharmacological effect, because of its ability to cause constipation, it is used for cases of diarrhea. Do you get it? Because of its ability to cause constipation, to reduce gastric juice secretion, peristaltic activity, it is used for, so when someone has diarrhea, what happens is there is frequent stooling, increased peristaltic activity in that case, and we want to reduce it. So your opioid analgesics come in handy in that situation. But this is not for children. You don't use these medications for children. Alright? So the drugs that can be used there, you see different preparations. You have your codeine, diphenhexylate, and loperamide. Those are opioid analgesics that are used in your anti-diarrhea preparations, but these are not to be used for children. Contraindications are stated here. There's more there. So let's go general anesthesia and premedication, chapter 6.9. So that's that for your opioid analgesics. In the treatment of diarrhea in children, what should you do? What should you use for treatment of diarrhea in children? Pardon? Sugar. Huh? Soda. Sugar salt solution. Your oral rehydration solution. Is that what you mean? Do you know how to prepare the homemade preparation of ORS? So that is what you give when the child has diarrhea, not any of the medication that we have, except if it is, there are some special risk cases that you want to quickly refer, but otherwise you just keep rehydrating, ensure the child is well hydrated. All right, I'm sure you can teach me about that. I don't have to teach you about dehydration and diarrhea. Okay, so anesthetics and premedication. Where is this general anesthetics and premedication? Where is it relevant? In which situation is it relevant? Surgery. In surgery. Okay. Long, short, long, and even short. Premedication and even whether it's long, whether it's dental, or short. So general anesthetics are very important for that. So we need to know where we're going to use them. Okay. So what do we need to know when we at the end of this lesson? So first and foremost, we need to know the typical sequence involved in inducing general anesthesia. How does it happen? What do we do first? What do we do second? What do we do third? And the reasons why we need to pre-medicate, the reason why we need to induce anesthesia, and the drugs, the common drugs that are used for such. And then we need to be able to differentiate between your IV, volatile, and gaseous anesthetic agents. Okay, so this is a typical sequence for inducing general anesthesia. First, you do what is called a pre-medication, and then there is the induction of anesthesia, and then there is so on inducing anesthesia, it also needs to be maintained. Okay, so there is induction, there is pre-medication, induction of anesthesia, and maintenance of anesthesia. With pre-medication, we'll see the steps that are followed in the next 1 or 2 slides. But to induce anesthesia is usually done with a rapid-acting IV drug. So when you want to induce anesthesia, you use an IV drug, a rapid-acting one. But the maintenance can be done with your gaseous, with a volatile anesthetic agent. What is the essence? Why do we need to? Yes, we need to use it in surgery. But why do we need it in surgery? Why is anesthesia needed in surgery? To sedate the patient. Why do you want to sedate the patient? So they don't feel the pain. They don't see what's happening when you're putting that tummy. You were sitting there and seeing your open tummy. All right. So that's for the patient to be unconscious, and sometimes some of the surgeries take so long that you don't want to. And then if you're not, so what else does anesthesia do? Sedate the patient. One. Okay, so we said when you cut somebody, what happens to the central nervous system? Inflammation. A signal is sent that there is pain. You feel pain. Inflammatory pathway, the pain pathway, immediately is generated. So when you're cutting somebody in surgery, what else is the person feeling? What are you supposed to be feeling? Pain. So sedation. Anesthesia is also to produce analgesia. Analgesia, sedation. What else don't we want? You want to dry off mucus? Okay, what else? Pardon? Counteract nausea and vomiting that might occur. Okay. So. Okay, when we sedate the patient, okay, this is a sleeping already, and okay, so that would, yeah, that might work. Pardon? The blood coagulation. So they would use anticoagulants for that. Yes, if it's definitely, because blood naturally would. No, that's not. We're not told that. Okay. Okay, so we induce the analgesia with a rapid IV drug. Okay, maintained with a volatile relaxant. So we want to ensure that the patient is sedated. We said so. The patient doesn't feel pain, analgesia. What else? Mucus is dry. There's no mucus secretion. Okay, so that the patient doesn't gag on their own accumulation of that, and then the patient, what is this? Hypotension? No, HYP, not Hu. Okay, so during that process as well, certain antidotes are made available to ensure that, if need be, that the patient, during the surgical procedure, the patient is attached to all these gadgets that monitor their vital signs. That if need be, for any of hypotension, cardiac arrhythmias, convulsion, if they need to give the patient an additional medication, they have the antidotes ready to help to ensure that the patient is still, even though unconscious, but is still lives through the surgical procedure. Muscle relaxants are another thing. Why are muscle relaxants necessary? Muscle relaxants are also used as part of your general anesthesia induction. Why is that necessary? Let's stick it on. Okay. So we've seen that we have pre-medication, we have induction of anesthesia, and then we have maintenance of anesthesia. That's the typical sequence for general anesthetic procedure. So anesthesia is a process of relieving what would I describe now? Analgesia is a process of relieving pain without causing unconsciousness. Do you agree with me? So if I say compare anesthesia to analgesia, compare anesthesia to analgesia. Analgesia relieves pain without causing unconsciousness. Anesthesia relieves pain and causes unconsciousness. So anesthesia, let's start with analgesia, which we're very familiar with. is the process of relieving pain without causing, without losing, okay, let's use, without losing consciousness. Let's use that word instead. Without losing consciousness. While anesthesia relieves pain, remember that part of analgesic anesthesia is to relieve pain generated. But unconsciousness, with a loss, let's say with a loss, let's use the same word, without a loss, with a loss of consciousness. More often than not, depending on the nature of the surgery, is with a loss of consciousness. But with your dental procedures, the minor procedures, there might not be a loss of consciousness.
Sorry, also antibiotics obviously have to be used as well, right?
Antibiotics have?
Sorry, I'm saying obviously antibiotics also have to be used in the procedure.
In the procedures, very true. Very true. Antibiotics are used in the procedures. Usually your IV antibiotics, as much as they try to keep the environment very sterile, but they do use antibiotics to ensure that there are no infections. You know of nosocomial infections, infections that are gotten from the places of health delivery. All right, let's run. We should be done very soon. Okay, so we know differentiate between anesthesia and analgesia. So we are trying to relieve pain and during the surgical procedure, but the patient might need to lose consciousness in anesthesia. So that's why your anesthetic agents will cause non-specific depression of the CNS. Okay? Because of the need to cause unconsciousness. Okay? So there is also the absence of all perception of sensory modalities and muscle tone. So the patient does not know perception of sensory modalities. Anything that is happening, their unconsciousness is what? Inability to understand or participate in whatever is happening around you. So they lose muscle tone. They can't move. All right? Yes. But there is loss of consciousness without loss of vital functions. And that's why the guards are attached to the patient to ensure that the vital signs, and you have those antidotes there, the vital signs, hypertension, cardiac arrhythmias, they quickly give an antidote to push it back because the patient should not die during a surgical procedure. Okay, loss of vital functions. So patients usually cannot be roused by external factors. So if you put a patient under anesthetic conditions, you can't tap them, wake up, wake up, wake up, wake up. You need to reverse the situation. So a balanced anesthetic process would involve using the correct degree of sedation. So that's why anesthetics is a specialization. As after being an MDE, you need to go and do a specialization as an anesthetic specialist. Okay? So it's a specialization because it's quite it's a fragile process. You need to use the correct degree of sedation because there's how you will sedate that there will be respiratory depression. Remember with our opioids. Balance involves the right amount of loss of consciousness, and analgesia and muscle relaxant as well needs to be relative to the procedure that the patient is being exposed to. If you don't sedate, if you don't anesthetize the patient enough, and there is not enough, the anesthetic agent is not giving enough analgesia, when you cut, the patient can jump up because they can feel the pain. So it's important to have the correct amount of analgesia and muscle relaxation produced. I don't know if you probably, the South Africans wouldn't be very aware. Are there any other persons from any other part of Africa here? Any other countries in Africa? Any person here? Have you seen, do you kill chickens? I know.
Yeah.
Have you seen when you cut the head of a chicken and the chicken keeps running? Oh, you see? Oh, sorry, I thought you were very recognized. Pardon? You do have to cut chickens at home. Is it allowed? It's allowed. Interesting. So you cut the head of the chicken and the chicken keeps running. You have to hold it down. Okay. All right. So the pre-medication process is what precedes the induction of anesthesia, and the main, the target of pre-medication is to ensure the patient is well sedated, to ensure the patient drying up of the mucus, the prevention of nausea and vomiting, and oh my goodness, I'm so sorry for this. Sorry. Yes, and that analgesia is adequate. All right, and so the drugs that are used. Okay, so if we have all this, I'm going to do. If we have all the sedating the patient, drying up mucus, and counteracts nausea, which class of drugs are we going to use for this patient during the process of pre-medication? During the process of pre-medication, which class for sedation? We already did this before. Let's just read it again and get familiar with the drug classes. Sedation would be your. Which drugs can we use for sedation? Your psychiatry pharmacology.
Ketamine.
Benzodiazepines. Yeah. Diazepam. Lorazepam. What of drying up mucus? Anticholinergics will work there. Nausea. What? Which drug? Antiemetics would work there. Antiemetics, okay, let's do that. Antiemetics. That's the drug. Then obtaining analgesia. The last one, obtaining analgesia, opioid analgesics would be useful there. So if you remember the process, what we need to achieve with pre-medication, and you know the classes of drugs that are used for each of those pharmacological effects that we want to achieve, then you already know the drugs you would use for pre-medication. So tie the pharmacological effects we want to achieve to the classes of drugs that produce such pharmacological effects, and then you are good. You won't struggle to know the names of the drugs that are used for pre-medication. So we said anticholinergics for mucus secretion, all right, to reduce secretion. And entropine is a very good example. Your glycopyrrolate is another example. They also help with hypertension and they can cause hypertension and bradycardia. That's one of the side effects of atropine. Antihistamines will help with sedation and antiemetic properties. All right. So your sedative. So that's why when you say antiemetic, I still want you to say something else because they fall under antihistamines. Sometimes you find them under antihistamines or anticholinergics. So when you say antiemetic, I'm looking for another word because you can class them under these drugs. Okay, so promethazine and hydroxyzine can be used for that. Your analgesia, definitely your fentanyl and petadine-morphine can be used. For sedation, diazepam, lorazepam are used pre-operatively. So you use them before you sedate the patient, before your pre-medication, before you start the operation. Then neuroleptics can be used for sedation and antiemetic activity as well. So that's for your pre-medication. Now for anesthesia, inducing general anesthesia itself, the drugs that are used are divided into two. You can have the intravenous one and you can have the inhalation kind of anesthetics, all right? Your intravenous ones, we said, are used for the induction of anesthesia. So that's the first drug that is usually given, used for rapid induction of anesthesia. So they can be used sometimes for light surgeries, like your oral surgeries, your dental surgeries, you can use just that alone will suffice. You don't need to maintain in such cases. And how are they gotten out of the body? So when you give them, the drug needs to go out of the body some way or the other through renal excretion or biotransformation. Examples of your IV anesthetics are sodium thiopentone, etomidate, ketamine, propofol. So I want you to take note of the fact that ketamine is a potent analgesic. It causes potent analgesia, so it's very, very good. The patient will not feel any pain. But it causes dissociative anesthesia, it causes hallucinations in the patient, and is suitable for pediatrics, for shock, asthma, and massive injuries. Your sodium thiopentone does not have analgesic property. Okay? It doesn't have analgesic property. It's a short-acting barbiturate. Etomidate does not have analgesic property. Okay? It doesn't have any hangovers, but the injection is painful. Propofol can be used for both induction and maintenance of anesthesia, but unlike sodium thiopentone, the recovery is very rapid with this, but it may cause hypertension. So we've induced with your IV anesthetic. Now we want to maintain the anesthesia. Then we will use our inhalation anesthetics. Okay, inhalation anesthetics, and inhalation anesthetics are usually made of highly lipid soluble substances. Why is that necessary? Highly lipid substances that can cross the blood-brain barrier. Okay, highly lipid substances also can be stored in fat in the body. Okay, so those are ways of maintaining or sustaining the medication in the body. And the lipidations of volatile, the most common one is your nitrous oxide, also known as the laughing gas. Okay, the volatile one is allopurinol, and so they're generally used. Guys, just read of that one. Okay, generally used for these purposes. Yes, blood gas partition coefficient. Blood gas partition coefficient. So allopurinol and eflurane are used for induction. So for you to maintain, for maintenance of an anesthesia, the patient might need to wear some gadgets like a face mask and a flow meter to monitor the amount of the anesthesia that is going in to the body, and is transported in air or oxygen or nitrous oxide. Of course, it is conveyed to the blood, and then elimination is via the lungs. But what is blood gas partition coefficient? Okay, that's an assignment for you. So it's about the solubility of the anesthetic agent. But just read it up. It's well explained in your textbook. All right. The blood gas coefficient talks about the solubility of the anesthetic agent. So nitrous oxide is a laughing gas, also referred to as laughing gas, potent analgesic, used for that. Allopurinol and the others, read up more of that in your textbook. Then another one, eflurane. Well, you can focus on the three that I've mentioned here for your tests. For exams, we look at everything, but for tests, you can just focus on what I have outlined there. But read up the others as well in preparation for your exam as well. Allopurinol has an advantage because it can be used for both induction and maintenance, and can be used by or for asthmatic patients because it causes bronchodilation. So for an asthmatic patient, the stress of the procedure would help them preserve them from having bronchoconstriction and going into an asthmatic attack. but it may cause arrhythmias. Shoot, that's been very wrong, that toxicity. Eflurane's advantage is that it has excellent skeletal muscle relaxation, and it can be used for induction and maintenance. But it also reduces cardiac arrhythmias. That's one of the advantages of your Enflurane. Then we read up the other ones, and that would be that for this lecture for the week. Do we have any questions?
Sorry. So, the next class that we have next Wednesday, is that going to be included in the test for that Saturday?
Okay, so I had explained this in the previous class. No, I explained this in this class last week. So, because our topics are moved up, we didn't start with the CNS. We're just taking part of it in this lecture. Does anyone have a copy of the schedule here? I brought it to class last week, and I explained to them. So the lecture on the test is on the 5th. The lecture on the 14th, or when is the next lecture? No, it can't be 14th. The lecture on the 2nd. When is the 2nd? Is it next week? Next week is included, definitely. It's before. It's before the quiz. Any topic we do, okay, so let's just make it a blanket statement. Any topics we cover before the test is part of the test. So the Wednesday before the test, the lecture would have on that Wednesday, which I think I've adjusted your schedule also on eCamera. So whatever lecture we have before the test is part of the test. One thing that I would have loved to show you now, let me see if I can get on eCamera here, is that unlike what we had before, where there was a lecture after the quiz. What was that now? GIT or something. I can't remember. What's our next topic? Is anyone on eCamera? Please help us. Can you get on eCamera quickly? Who is on eCamera? Please. Because there's a topic that was supposed to be after the test, which is now going to be before the test. Okay? Because we moved our topics up. So it's not going to be before the test. So that topic we're going to do the week before, the Wednesday before the Saturday of the test, is also included in the test. Are we there? But I think I've already adjusted it on eCamera. Anyone there? Tell me, which is that topic that was initially, where are you?
Chapter 14, drugs affecting the blood.
Yes. Drugs affecting the blood. Oh, so is this, did you go on eCamera now? This is the old one, because I adjusted it on eCamera. So your drugs affecting the blood are now going to be part of the test, because we're going to do it before the test. So that's our next, probably our next topic. Pardon? Which psychiatry? Did she say she's going to include it in the test? Or did Dr. Van Houston say she's going to include that topic in the test? Did you do it before or after the test? So if you did it after the test, it's going to be part of this test.
She said it was, we did an assignment on it.
Okay, okay. So she said,
It's part of the assignment.
do it in the test. Okay, so it's just going to be my topics then. Okay, so usually what we do is whatever was before the test was included in it. But if she's taking it out, because she's already marked your test, I'm just she doesn't want to mark your test again. Yeah. So all my topics before the test are part of the test. Alright.
sorry, and the last question. See, there's a psychiatric oncology quiz too.
Quiz two.
So we got another quiz. Another psychiatric.
Can you access it? Can you access the quiz?
Yes, but I heard some people said it's for students that couldn't write the previous one.
Okay. Is it, if you can access it and it's the same question, then you don't need to attend to it. Except you don't, I don't think it's open to you. Really. Maybe just want to give you another opportunity. So I will also, I already uploaded a set of practice questions, all right, as an attachment, because I just wanted to play around with those questions. But the quiz that we count for marks, I will do before the end of the week. So I probably would have put my quizzes, this lecture and last lecture, together, all right? But I'll put up also practice questions for this topic, just a broader set of questions, just to test you on every area possible. Because I found that with tests and exams, we can assess, I can't gauge your understanding. But with quizzes, I can gauge, not necessarily for me, but you can gauge your understanding because of questions. Like I had about 20-something questions there. If you look at all those questions, you'll be able to see if you really understood this lectures or not. And you can quickly come up and say, before the exam, sorry, I have a problem here. Please help me out. That's the essence. Yes, that's the essence of the general practice quizzes. And then there will be specific ones for marks. This is the new one. Okay, so this is a new one. Will now be part of the test. So, this is still the old one. Yeah. But we're doing that next now. Drugs affecting the blood. So we're doing next week, so it's going to be part of the test.
Yes, well, on the email we saw it is quiz 2. We didn't have quiz 1.
For Dr. Van Easton.
He said it is